Ladies and gentlemen, welcome once again to another episode of the Think Clinical podcast. My name is Hamza. Thank you so much. Today is going to be a very exciting day because whatever I'll be discussing here today, I have discussed this so many times, and you need to understand that this is becoming one of the biggest conversations in the industry. So what I need you to really do right now is look at your payroll. Just you're just going to look 3 years back. Don't go too far. Just look at your payroll, right? Look at your supply costs. Look at your lab costs. Look at your malpractice premiums. Look at the subscription you pay on your electronic healthcare system, right? And I want you to compare those numbers to what they are today. Obviously, you are seeing that the majority of practice owners that I talk to are obviously talking about cost that is going up. And this is something that we are experiencing in my company too, because we are beginning to see a lot of costs associated with these things going up. But then the other side of this exercise is that when you now translate this into the revenue, the reimbursement side, ask yourself, when was the last time you actually saw any increase in reimbursements coming from your commercial payers? And no matter how long I wait for this, you are probably not going to be able to tell me anything around this. So what I need us to understand is today is going to be the day that we look at some of these issues and how they are affecting our operations now. Because if you find cost of all these things going up and your reimbursements stay flat, and if you hedge that against inflation, you do realize that you do not have any value to what is happening right now. You are losing a lot of margin, and that is going to eventually crumble your business. So let me give you some statistics before we even jump into anything remotely relevant to what I'm trying to talk about, and just how you can navigate some of these things. So when we look at this, one of the biggest cost drivers that you see in your healthcare practice, whether it's a dental practice or it's a medical practice, is going to be around labor. And if you're lucky, you'll probably be spending between 54 to 56% of your revenue, adjusted production in some senses, or collections in some situations, which is the same over a period of time. You're going to be spending that much in labor. Now, just so you know, labor cost has increased by 4.3% between 2024 and 2025. And if that doesn't make any sense to you, between 2023 and 2024, we are fully seeing like a 2.7% increase. So if you look at how quickly all these costs are going up, it's becoming difficult and is gradually creating a shift. And especially when you look at the nursing shortage, that is now projected to hit about 3.2 million by 2030. Basic economics 101 will tell you that when demand exceeds supply, and when supply cannot meet demand, then you know there's going to be trouble, because costs would obviously go up again. Now, when we look at the cost side and we look at the reimbursement side, and I like to use Medicare as an example. In 2024, you realize that Medicare reimbursed hospitals just 83 cents on every dollar. So if you look at this across the spectrum of hospitals that were reimbursed through Medicare, about 100 billion in underpayments were recorded over the year. $100 billion. So for physician practice specifically, Medicare payments have declined by 33%, because if you look at this inflation adjusted terms, or if you look at this in inflation adjusted terms, from 2001 to 2025, that is declined by 33%. Now put all these together, this is huge, because when you see if you just want to break even from a 6 to 7% rise in operating expenses, on the commercial reimbursement side, you need to have an increase of at least 14% just to break even. So what this is telling us is that we're just pushing and fighting against some very difficult situations that we need to be more strategic when we are approaching. Now, if you look at a real case study, and I'm actually not going to use an actual case study, but if you are listening to me right now, you run a medical clinic, I would assure you that 95% of you will fall into this category. And if you look at let's say 4-physician practice in a suburban market, and they have a great reputation, they have great patient or full patient panels, And in 2022, let's say they were generating about 4.2 million revenue. That looks really healthy. But over the next 2 to 3 years, they hired 2 medical assistants at significantly higher cost because they have to be able to meet the challenge of what competitors next door are actually throwing at them. And at the end of 2024, they realized that their operating margin had compressed from, let's say, 11% to about 4%. They had no cushion for a bad quarter and no capital for growth. So one physician starts talking about selling, and this is a problem that most people are going to immediately have conversations on, and these conversations are more and more as we go through some of these issues. So the problem wasn't the fact that these clinicians were running a bad practice. The problem was the fact that they were running the practice the same way they would have been running it in, let's say, 2010, when things have evolved so much and they have to really adjust to what those changes look like. So today, let's look at those changes. And as I said, this is going to be straight to the point and tell you what you need to be able to pay attention to. One, you need to audit your overhead like a CEO, or like a CFO, sorry, and a CEO, obviously, because when you are a practice owner, if you're a physician leader especially, we look at our P&Ls monthly. So you pick up the problem a month later after it's happened, and you are now trying to go back and fix a problem that has really occurred in order to prevent it from occurring again, which again puts you way behind what you're supposed to do. Now, looking at this as a CFO means that you are going to be very closely monitoring and auditing this weekly. What this means is that you're not going to just be looking at just total expenses. You're going to be looking at very granular details. You're going to be tracking expenses or cost per visit for every patient. You're going to be measuring cost per clinic hour. You're going to be looking at revenue per provider. You're going to be looking at all these ratios in a way that would give you enough information quickly for you to be able to act on it. The audit is the biggest stage for you right now. And if you look at vendor contracts that auto renew at maybe 15% premiums, then you're able to catch all those quickly. You're able to go back and renegotiate some of those vendor contracts. So that's the first thing that you need to do. The second thing is that you need to rethink your staffing mix. Now, this is one of the most underutilized levers that private practices usually use. So let's say we have a physician generating about 350 to 400,000 in collections in a year. To hire that physician is somewhere between 300 to 350, and the same for nurses. Nurses will generate between 200 to 250k a year. To hire that nurse is between 130 to 160. So the conversation here is not about just replacing physicians. It's about strategic delegation. The practices growing right now have shifted to physician-led, mid-level supported care models that expand capacity without proportional cost increases. So you have to be able to think about this. So the second thing is your staffing mix. The third thing you have to look at is reducing your payer dependency. Now, this is an uncomfortable conversation for most people, because the moment you talk about this, that means we are moving out of our comfort area. Because when you look at direct primary care practices, for example, they charge patients a flat monthly fee, membership fees, typically $50 to $100 a month, and opt out of insurance billing for primary care services. And when you talk to these direct primary care owners, let's say running 2 physician practices with overhead of about 40%, you actually realize that these are going to be very huge margins for them, or good margins for them to be able to go home. So you don't have to fully go cash pay, but you need to think about models that would improve your reimbursement rates, because the cost is not coming down, and it's probably never going to come down. It's probably going to go up. So you have to find ways of making this. This is very uncomfortable for most physicians, so we have to look at this very closely. The next thing is to anchor your revenue in what we call ancillaries. So there are things that like labs, like imaging, like physical therapy, that you usually have to refer patients out to. Now you have to, if you can bring some of these things in-house. Let's say labs are one of the easiest things, and with probably like a $40,000 investment in a period of 14 months, you should be able to at least turn around, let's say, $200,000 annually. That's a good, huge return on your investment in less than 2 years. So think about how you can bring some of these things in-house to be able to generate more funds. And then the fifth strategy is for you to treat billing as a revenue strategy and not a back office function. Because when you look at how much your billing team is leaving on the table, and this is across the whole industry, between 15 to 30% of collectible revenue are left on the table. So let's say you are running a $3 million practice. It means that every single year you are leaving $600,000 on the table. That is revenue that you need and revenue that you can definitely collect back. And the last thing, which is usually and which is the most popular thing that we have right now, is the use of AI. Now AI is everywhere. Everybody is talking about AI. Everybody has an AI solution. You need to be able to look at what actually works in practice today. Do you and I'll have another episode where I talked about all the things that work, but prior authorization automation, ambient documentation, these are huge in the industry right now. Like AI ambient education, we are looking at some products right now for our group, and you usually would see that it listens to patient encounters and is able to draft notes. It saves physician time about 1 to 3 hours a day, which is significant for physicians, because going back to write notes is the biggest one. And a world where physician burnout is the biggest retention risk, this is not a small thing. This is huge for what we can accomplish altogether. So here's what I want you to take on from today. That margin squeeze is real, and the numbers are going to keep hitting you hard, and it's going to get harder before it gets easier. But the practices that are building for the next decade are not waiting for payers to act or for Congress to fix Medicare. They are auditing relentlessly and diversifying revenue and deploying technology strategically. You need to be able to look at some of these together and prepare yourself for the next generation, or the next decade, sorry. This is another episode of the Think Clinical podcast. Thank you so much. It's always good to be here. Remember to subscribe, like, and share, and we'll see you in our next episode.